Good morning, sir. A warm welcome to TRICO 2018.
Thank you very much. I'm very pleased to be here.
How is your overall experience of TRICO 2018?
Well, we haven't finished yet,
Yeah.
but it's been very positive. The, uh, the the venue, the case selection, and the way everything has evolved with the very high quality of the cases, but particularly with the transmission and the faculty discussion, been very, very positive. And of course, the warm welcome we get from everyone and the hospitality is really very special.
Fine. What is the level of education of TRICO 2018?
Oh, it's really superb. You know, Dr. Patel is a master. Again, his selection of cases has been very, very thoughtful. So every case has been selected for one or more teaching points, but also the way he interacts with his faculty. He knows all of us. He knows our strengths, our weaknesses, and so he knows exactly the right questions to ask us to get a very good discussion.
Great, sir. What do you feel about the different technologies being used in TRICO 2018, like OCTs, the robotics, dorsal transradial approach?
So I think with all of these things, we don't know. So anything I have to say is just purely a guess. With the dorsal approach, I'm not sure. I have to say I've never done this. My colleague here, Dr. Galati, has done two or three. I'm not sure what the advantages are, but I think we need to wait for some more experience.
Right.
So at the moment, to be honest, I don't feel that I need to do this at the moment, but I will wait and see, and we'll change our practice if we see good data supporting this. I think with OCT, the OCT demonstrations that we've seen have been absolutely phenomenal. Dr. Akasaka has been a wonderful person to have here. He's so facile with the OCT and particularly with his interpretation, and I think we've all learned a lot from that. I think everyone has learned a lot to have a master like him. The problem with OCT, particularly in the United States, is that it's expensive. And so if we were to use this in every case, it increases the cost of the procedure. But I think it gives us some extraordinary insights into what actually is going on with these stents. And so I'd like to use more of this, but the cost has to come down. But you can see that particularly for answering research questions, this is invaluable, for the future. I think the robotic assisted PCI is much more interesting. Um, we know that interventional cardiologists are concerned about the risks of radiation exposure. We wear these heavy radiation protection garments, aprons, whatever you want to call them. But there is a dark side to that. There's a burden we have to bear, and that is the risk of musculoskeletal, particularly neck and back problems. And so anything that we can do to move away from the radiation and not to have to wear these heavy protective garments is a good thing. And so we saw some nice examples of how the robot can now help us, particularly with the second iteration of this. The problem's going to be, and we discussed this yesterday, is how can we prove that that adds value to the procedure from the patient perspective? So is the clinical outcome going to be better? And I think many of us find it hard to believe that we'll be able to prove that. On the other hand, I think that we may learn things from this. There may be some very smart people on the side who see now how you can use it for something else. I'm a great believer in technology. I think that, as I mentioned yesterday, one potentially could see a world in the cath lab in the hospital where a patient comes with heart disease and that we perform advanced CT imaging. It could be MR, and and even better than what we have today. And we're able to assess the anatomy to a very high accuracy, measure the physiology, and then when that patient then comes to the cath lab, we already know exactly where the blockage is. Maybe we incorporate artificial intelligence, and now we have a robot that actually performs the entire procedure without us controlling the robot. We have to understand that this is not really robotic PCI, it's robotic assisted PCI. And so if you provide all the information to the robot, and I'm talking about a mapping of where the arteries are, starting at the radial artery, coming into the coronaries, know exactly where to put the stent, what size stent, and then all you need to do is just to watch it to help it if it needs some help. But that's in the future. That's not next year. It's not 5 years, I don't think. Maybe 10 years. And I mentioned yesterday the analogy of the driverless car. Many people are very skeptical, but it's hard to believe that in the future these will all be driverless cars. Even here in Ahmedabad, we might see this. That maybe takes a bit longer. But I think that that's where the technology is going to go. But this is expensive technology. And so I think we have to study it very carefully. And I don't think that suddenly we're going to put robots into every cath lab. Certainly not in the United States. We won't be able to afford this. The hospitals won't buy these machines. We have to prove that there's better patient outcome. And I think that's going to be the struggle.
Thank you very much, sir.
Okay, thank you very much. My pleasure.